good evening and welcome to the Open Classroom. My name is Ted Landsmark. I am director of the Kitty and Michael Dukakis Center for Urban and Regional Policy within the School of Public Policy at Northeastern University. And we get together each Wednesday night to have free-flowing discussions, questions, and answers this semester on the subject of what can we anticipate in a post-COVID world? What are the kinds of things we need to be thinking about? What has this pandemic opened our eyes to? And this week, we're going to deal with a subject that is in the news quite a bit, and that is to say issues around health. I will say that much of what we see in the media relates to numbers and quantitative assessments of healthcare. But tonight, we want to dig a little bit below those numbers to speak to researchers and practitioners who are dealing with some of the deeper issues that have come up in terms of healthcare. I remind everyone that these sessions are recorded and that they are archived. And so if you know of people who cannot participate in tonight's conversation, they will have an opportunity to do that. You can do that by going to the Dukakis Center website, and we have all of our previous conversations recorded. If you have questions, we would appreciate it if you would enter those questions into the Q&A box, and we'll get to as many of those questions as we can this evening. And let me also give a heads up that next week we'll be dealing with resilience and sustainability with several of our faculty who have been working in that realm at Northeastern. The week after is a pre-election week, and we will be bringing in two faculty, one from the Northeastern Law School and one from the Harvard Law School, to talk about what we might anticipate. And the Wednesday after that is the Wednesday after the election. And we've put together what has started to feel like an old-fashioned teach-in, that is to say, an opportunity for a lot of people to weigh in on what the election results may be at that moment and what we can anticipate going forward. But tonight we're dealing with a subject that really touches on all of us. It has touched on the way we interface with our families, our communities, our friends, with our work colleagues, and that is to say health and healthcare. Particularly as it has been impacted over the past 8 or 9 months. And with that, I want to turn our facilitation and our conversation over to my faculty colleague, Tim Hoff, who has been deeply involved in healthcare and healthcare research for many years, and who I am pleased and honored to have as our guest opening voice this evening. So Tim, you're on.
Thanks, Ted. It's really nice to be here. I appreciate serving on this panel with Stephen and Greg and yourself. And, you know, I have a lot of respect for the organizations that Greg and Dr. Wright, you know, work for, really being on the front lines of this. You know, not only the pandemic, but, you know, trying to get healthcare to people in a difficult time. And so that's sort of what I've studied in some ways, at least since March 15th, which is, you know, what's really happening to healthcare, and, you know, while we're in the midst of this pandemic. So I'm going to hopefully set the table in some ways for some Q&A and some dialogue, and also for some further, you know, analysis and firsthand experience from Dr. Wright and Mr. Wilmot. So I'm going to talk about some bigger picture things that have happened. I'm going to talk a little bit about the innovations that have been spurred because of the pandemic to get people care. Talk a little bit about the pros and cons of that. And again, talk about some of the barriers and some of the issues, particularly for vulnerable populations that, we're looking at right now. So I'm going to, forgive me, a professor can never go far without a PowerPoint slideshow. So I'm going to, I'm going to bring up a little PowerPoint slideshow because I think it's helpful as we go through this. Okay. So hopefully you can see this. And just get the slides. There we go. So let's talk a little bit about how healthcare has already changed because of the pandemic, right? And again, these are sort of broad stroke realities, okay? But they're real, right? The first thing is, and I'm going to spin this, I guess, in as positive a way as I can. The whole issue of healthcare access for patients, I think the pandemic is forcing us to what I would use the term reimagine access for a lot of patient populations. Really for all of us, though, at least for that period in the spring when we had the shutdown. And we'll talk a little bit about what reimagination means. Some of that's positive because we got care to people quickly, and we did it in ways we maybe didn't think we were as capable of. But there's some potential negative, realities and fallout that we need to understand from that. One is that there's been disproportionate effects of the access issues and the access innovations on vulnerable populations, right? So I was looking at a study that was just published in the CDC's Morbidity and Mortality Report, a really good study by Seisler and colleagues, which used a very good data set to show that, during the time period from mid-March through the end of June, of thereabouts, most Americans, a good proportion of them, sacrificed care. They could not get into care, or they decided that, they would not seek it out. Those effects, though, what the study found is that those effects of not being able to access needed care fell disproportionately on, for example, Black and Hispanic patients. So the study, again, with a very large data set, found that Black and Hispanic patients were 1.5 to almost 2 times more likely not to seek urgent or emergency care during that time period compared to white patients. Okay, so, confirming what a lot of other, both anecdotal, information, news articles, presumed and showed, which was that, the effects of not being able to access care has stratified into the population very differently. And also in that same study, the other interesting finding was that those who were commercially insured, as opposed to those who were insured through a public program like Medicaid, were much more likely to have not delayed care and to have access needed care than those populations on, for example, public insurance. So the access issue has been an issue for all Americans, but it has fallen disproportionately on vulnerable populations. And my colleagues who work in organizations that serve vulnerable populations, I'm sure will be able to speak to that much, much better than I can with just one study. The financial situations of providers is also shifting, and it's shifting rapidly. The pandemic, by taking away a lot of revenue streams suddenly from, I study primary care, from for example, primary care practices, it has put a decent percentage of those practices in financial hot water. So much so that, there's a fear, especially if there's a second wave that shuts care down, that some of these smaller primary care offices and practices may go out of business, within the next year. Some estimates are anywhere from, 20 to 25% of smaller primary care offices. And certainly in places like, federally qualified health centers, rural health clinics, the financial situation has been strained again because revenue streams were cut suddenly because people could not get connected with needed care. the issue of provider needs, things like burnout, which were already, at crisis levels prior to this. The pandemic has sort of exacerbated that. We know the stories about, providers working in hospitals and on the front lines, in ICUs and emergency rooms. But there's also issues. I'm doing a study now, talking with primary care doctors. There's also issues, for example, with primary care doctors and providers becoming more prone to things like burnout, simply because of what they've been asked to do during the pandemic to again, try and get care to people. And then we've just had the general trend of patients that, even as we've come out of the lockdowns across various states, there's evidence that shows that patients are still, a certain percentage of patients are still reluctant to seek care for whatever reason. It may be older patients who don't want to go out of the house. They may not want to do telehealth. But there's a general sense that people are still delaying needed care, okay, as an outgrowth of the pandemic and more specifically the shutdowns that occurred. And so the marketplace is going to require more of what the marketers would call pull strategies, right? To get people to actually get in and get needed care. We can talk about what that means and how that actually can be done. And I'm sure my colleagues are already doing things like that. So here's just a very brief timeline, right? And again, this is oversimplifying things, but fairly accurate in the broad strokes, right? So in March in Massachusetts, right, we pretty much had a temporary shutdown of everything but emergency services, right, for, at least a week or two, as people really tried to, and particularly in primary care, tried to rapidly shift to telemedicine, okay? Specialty clinics, specialist physicians, specialty care, I think was slower to make this shift. Why? Because many of those specialties are procedural. They're actually doing things to patients, and they were not able to do that. But primary care took a little bit of time to shift to telemedicine, and it took a little bit of time to work the rules out and get payment parity. The things that were going to allow doctors to be able to, and providers to be able to provide care through telehealth. So, the end of March, beginning of April, there was a lot of care that went undone, right? And then in April, and I'd say April to June time period, you had a lot of, particularly in primary care, a lot of providers and offices really adopting telehealth fairly quickly. I mean, I've been studying this somewhat. People in primary care sort of chuckle a little bit, and they say, what took, 1 month, telehealth took 1 month in the pandemic to be implemented on a wide scale, whereas the 10 years before, you couldn't get many doctors or providers to want to do telehealth at all. And so part of this was, again, a lot of offices facing just very large and sudden revenue drops. And they simply had no choice but to do telehealth. And then the other issue is that, there were many of their patients were in need of, whether it was chronic disease care, substance abuse treatment, and there was no way to get those patients in. So April and June was kind of a mix. I think depending on what practice you talk to, some practices I've talked to said they were doing, 70% telehealth and 30% in person. Others were saying they were doing 50-50. Practices in primary care, for example, were still trying to get people into care that needed to be seen in person. But the other barrier was just the whole triaging thing, right? If somebody showed up with symptoms, offices had to have a very sophisticated triage process, or they just simply could not take them at all and had to turn them away, either do telehealth or push them to an urgent care center. There were also technical barriers, right? Technological barriers to virtual care. So I think, a lot of medical practices were able to quickly embrace, telemedicine, but on the patient end, and again, particularly, for vulnerable populations and poorer populations, which may not have access to high-speed internet in their homes or, fancy, gadgets to get telemedicine, that sort of healthcare delivery has ended up, I think, taking longer for those populations. And so those barriers, I think, still exist. And obviously we had things like surgery and other specialty services that were just fully delayed. Then as things started to open up again, up till now, right? I would say you have, especially in like places like Massachusetts, you have New York, you have a slow return to in-person primary care. You have elective surgeries, starting to rebound a bit. And what I have read, and in some of my research, what I've seen is I've seen offices that have sort of, wanted to go back to really doing in-person care. So telehealth use in many, for example, primary care offices, I think, has probably dropped, certainly below levels where it was back in April and June. Part of it too is the worry that I think a lot of providers have that the compensation parity, offering reimbursement for telehealth that's the same as the same service that would be provided in person, that prior to the pandemic was not, telehealth paid less. People are worried that, Medicare and private insurers, are going to go back to essentially, under reimbursing telehealth. And so many of them, at least ones I'm talking with, have told me that, they're very worried about that. And then, post-pandemic, whenever that is, I think we're going to see permanent changes because of some of these financial strains on existing service providers is going to play out. You are going to see a lot of service providers, big and small, downsize. You're going to see some go out of business. You're going to see some reinvent how they provide care in a way that's much more efficient. And there's good things to that, but there's also, changes for patients, I think, that occur because of that. And then all throughout this was the whole notion of like, how safe is it to really access healthcare delivery? How safe is it to go to a doctor's office? So this is just very quickly, when I talk about telehealth receiving reimbursement on an equivalent basis to in-person care. So this is from the Kaiser Family Foundation. These were some key changes, for example, to Medicare that were done quickly in order to boost up the ability for patients to get telehealth, right? Allowing beneficiaries in any geographic area to receive telehealth. Allowing beneficiaries to receive telehealth from their homes. These were all things that were not in place. Medicare did not allow prior to the pandemic. Being able to do telehealth with a new doctor as opposed to someone you already had a pre-existing relationship with. Allowing federally qualified health centers and rural health centers to actually provide telehealth services to their patients. And then allowing services to be delivered just through the phone, right? As opposed to, virtual through the computer screen or the smartphone screen. So these changes definitely spurred the drive in telehealth. Again, quickly, how has care been affected by these shifts and the pandemic? This is a study that just came out in Journal American Medical Association Open. And again, another good study. It just came out last week, data collected from 4,000 doctors each quarter. Here's some of the realities, right? What this database showed is a 21% decrease in primary care encounters in Q2 of this year versus Q2 in 2019. Okay, so that's a significant drop, right? 50% of that decrease was in face-to-face visits. Okay, there was a 50% decrease overall in office-based primary care during Q2 of this year compared to last year. The reason why the 50% turned into 21% is because telemedicine visits went up from 1% of all primary care visits in 2019 Q2 to 35% of all primary care visits 2019 Q2. So you see this huge shift to telemedicine. But at the same time, what this study shows is that some needed care by moving to telehealth was not either able to be done as effectively or was not done at all. So two crude proxies for, essential preventive work that you do in primary care. One was blood pressure assessment. One was cholesterol assessment. This database found that there was a 50% decrease in blood pressure assessment of patients seen in Q2 of 2020 versus 2019, and a 37% decrease in cholesterol assessment from 2020 to 2019. And then a 26% decrease in new medication visits from this year versus last year. The telemedicine visit rates in this data set for the Q2 of this year were similar in white versus black patients, although we know from the other study I quoted that, that may not be telling the truest picture of the disparity in how telemedicine is shaken out across populations. And then the commercially insured were more likely to use telemedicine than patients who were, on insurance like Medicaid. So this study, I think, is a really good one in showing that, even with the shift to telemedicine, there's care that's fallen through the cracks, right? And part of it is due to the fact that the technology may be limited in terms of, right, there's certain things you just are more likely to do or can do better when the patient is in the office. Okay, let me just do it for a couple more slides. And then, so what are the innovations that we're talking about here during the pandemic, right? The first, as we've talked about, is the use of telehealth and virtual care delivery. Overall, I think this is a net positive, particularly in areas like primary care. Although we have to understand that, it has the potential to exacerbate existing healthcare disparities, for example. And there's also issues around costs of care that we need to keep in mind. Telehealth is not necessarily cheaper than in-person care, particularly if utilization goes way up with telemedicine. And that's part of what the insurance companies are afraid of, that telemedicine becomes easy to do. And so there's more visits generated through telehealth. And if you have pay parity between telehealth and in-person care, the overall costs of care are just going to go way up. You've had the beginnings, I think, of a more significant shift to home-based and personalized care. We can talk about what that means and what that means for different populations. The idea of remote monitoring of patients, being able to use smart devices in their homes to be able to look at everything from their safety to what they're eating to, even their biological, functioning. That, I think, is going to be accelerated under this, particularly pushed by large systems like Mayo Clinic, Kaiser Permanente. You've had a lot of primary care office and visit redesign, right? Primary care offices just having to figure out ways to get patients in and out of the office quickly and doing it in a way that other patients aren't exposed to risk. And I think so some of and my colleagues can probably talk about some of the innovations that have been done at that level. And I think some of them are probably very positive for kind of reinventing, the primary care office visit a bit. The use of data analytics, to segment patients to try and pull them into care better. Consolidated care delivery, trying to bundle up services that patients need. I think that's been another thing that organizations have tried to work on during the pandemic. But again, the innovations will not be distributed necessarily evenly. And then to conclude, really barriers, some barriers here that we have to think about and we can certainly talk about to these innovations being more positive versus more negative for certain populations. One is insurance status, right? If commercially insured individuals have better access to technology and have better access to sophisticated telemedicine services, that's an issue to discuss. The out-of-pocket costs for some of these services may be equally high or higher than the traditional way of getting them. The ability for people to have the right equipment and technology in their house remains an issue. The differential capabilities of service providers and being able to provide in-home care, personalized care, and telemedicine. Patient demographics, as we saw in some of these studies, are definitely a potential barrier to the equitable distribution of innovations like telemedicine. And then the quality of the patient data that we're using to try and figure out how to get patients needed services, how to communicate with them that they need those services, and how to connect them with care. So on that, I'll stop and, maybe the thing to do next, I'll leave it to Ted, but might be interesting to hear from some of our colleagues about one or more of these sort of issues that I've raised.
Well, I'm going to ask that each of our health center staff introduce themselves and say a little bit about the health center that you're affiliated with, and just a little bit about the work you do and the kinds of patients and clients that you work with. Let's start with Stephen Wright, who is at the Whittier Street Health Center. And for those who don't know, Whittier Street is directly across the street from the Roxbury side of Northeastern's campus, and has in the past been a center that has also provided services for some Northeastern personnel. So Stephen, why don't you start up and tell us a little bit about who you are and who you serve.
Thank you so much, Dr. Landsmark and Dr. Hoff. That was an outstanding overview of what's been going on with COVID-19 since its inception here. I'm a physician. Fortunately, I've been able to be here at Whittier Street Health Center for the last going on 8 years now. I provide primary care. I'm also a surgeon, so I speak both languages in medicine, so to speak. And we serve our community, the greater Boston area. We are a primary care center, and we provide primary care. We have pediatrics. We have dental services. We do have dental and ophthalmology services here. We're basically a one-stop shop here. We're fortunate enough to have 2 sites, one right here on Tremont Street and one on Blue Hill Avenue, not far from here. We're very fortunate to be able to serve the community, and we do have a very close-knit relationship with the members of the community. We're neighbors with Northeastern, and we really enjoy the proximity. We still are able to see some of your staff and some of the students. We love to see them here. And this time during COVID-19 is something that we always thought would happen, but never really thought that it would really happen. It's literally a once-in-a-lifetime type of event that we never wanted to happen. And so for the scientists, it's incredible to be a part of this. As a clinician, it is devastating in every single marketplace, and everyone is being affected by this. So I'm fortunate to be here at Whittier Street, where we are trying to make a difference. Like I said, we have a close relationship with our community, and several points that Dr. Hoff made. It's going to be fantastic conversation this evening. And thank you for inviting us to be part of this forum tonight.
And could you say just a little bit about the distinguishing characteristics of the base of patients that you serve? Who is the community that you're serving?
Yes. So we see by and large, basically what we see right here in the Roxbury area. We have a large African-American community that we serve, a Latino community that we serve, a Haitian community as well. We see many patients that come from overseas, come from Africa, from Europe. We have such a diverse population here that we serve. It makes it wonderful for a clinician, from my perspective, to take care of them and to learn more about their culture. And we are culturally sensitive here, and we respect all cultures. So it's a very diverse mix over here, as well as on our Blue Hill Ave satellite. We have a slightly larger Caribbean, Haitian community over on that region. But we're here to serve, and like I said, I'm very fortunate to be here.
Greg, why don't you introduce yourself and say a little bit about your work in East Boston. Many folks only experience East Boston to the extent that they are coming and going to the airport and don't fully comprehend the richness of diversity within that community. So tell us a little bit about the East Boston Neighborhood Health Center, about the work you do there, and about the clients you serve.
Wonderful. Well, thank you and good evening. My name is Greg Wilmot. I'm the Chief Operating Officer, Senior Vice President here at East Boston Neighborhood Health Center. Dr. Wright, Ted, Tim, thank you for this evening. I think Dr. Wright hit on a number of things that community health centers do. We share many similarities to Whittier Street in that regard. Some things that are unique with East Boston, we actually operate a 24/7 emergency department. That is unlike most federally qualified health centers. I think we're one of the few in the state that operate a 24/7 ED. We are also the largest community health center in the state. We serve nearly 100,000 patients here. That makes us the largest in Massachusetts, but also one of the largest federally qualified health centers in the country. So we are a very busy organization. What I would say unique to East Boston, we serve probably about 70% of our patient population is Latino, which translates to our staff as well. We employ pretty heavily from the area, so many of our staff are Spanish speaking. And of course, with that volume of patients, it raises any number of challenges when it comes to health literacy, issues around immigration status and other things. Some unique considerations there, I think, as we get into the conversation that I'd love to share from the notes that I took from your presentation, Tim. In terms of some other, just our service area, we do in fact, service East Boston. I think we, probably anywhere between 60 to 70% of the residents of the East Boston community have a relationship with the health center, either through our primary care services or through other services that we provide here. But we also are involved with Chelsea pretty heavily, Revere, Everett, Winthrop. We actually have a Winthrop Health Center as well. We have a PACE program. PACE stands for Programs for All-Inclusive Care for the Elderly. That program largely services frail seniors, folks that are medically compromised, and might otherwise be in nursing homes if not for programs like PACE. And that program serves folks as far as Malden, Stoneham as well. So the health center is pretty large. We've also completed first of its kind in Massachusetts, a merger with another community health center. We did that recently. That was in July of this year. We merged with South End Community Health Center. So our service area now extends into that area of Boston. So we're kind of maybe a mile to 2 miles away from Whittier there. So we've experienced this crisis in a variety of ways, both as an emergency care provider, also as a primary care provider, but also as an organization that services extremely compromised individuals living in our communities that are frail seniors that were at unique risk for serious complication from COVID-19. So looking forward to talking a little bit about all of those different experiences and how we navigated that as an institution and the challenges that we're likely to step into as we go forward.
You're in a neighborhood that has one of the highest concentrations of COVID in the city. What is that like?
Yeah, so I think I'd appreciate Dr. Wright to comment as well, because I think we're starting to see some areas in Boston starting to have higher rates of infection as of late. But I'll just speak kind of most recently, as Massachusetts kind of came out of the surge in April and May and kind of emerged out of the summer in a slightly better place, certainly than April, May. What we saw in East Boston, this was probably, I want to say August, we saw a pretty significant spike in East Boston specifically as compared to other Boston area communities. So we were hovering, pardon my memory, we were probably hovering around 12% in terms of percent positive from a 7-day average percent positivity rate, which is one of the measures that we monitor pretty closely, which tells you kind of what's happening, in kind of real time in your community from a positivity standpoint. And so very concerning, because it was very much inconsistent with the results we were seeing across the state, as well as other Boston communities. So pretty immediately we partnered with other organizations, and I just want to, I'll if I don't say it enough, I'll talk about it quite a bit, of just how important collaboration in this state has been to the health system responding to this crisis in a very thoughtful way. But we partnered pretty early with the Boston Public Health Commission and City of Boston to really start to work on, number one, what was the data telling us, what was happening. We were looking at clusters of infection and using that data to really focus our efforts, but really kicked off a pretty aggressive campaign around just information and resources, making sure that folks had high quality information from trusted medical professionals, trusted sources. And we partnered with local business community, local faith-based organizations to make sure that both the trusted information was coming from trusted sources. And so that, I think, worked pretty effectively. We coupled the information with some PPE and hand sanitizer and things of that nature to kind of complement the message. So masks, hand sanitizer were some of the things that we included with some of what we call safety kits. And so we did a blitz of that in partnership with our local community and the Boston Public Health Commission. And what we did see, at least over subsequent weeks, is that positivity rate come down pretty drastically. It's still not in a place where we're comfortable, so we're still being particularly diligent about information. But it's now hovering around about 6% currently, and has been for the last few weeks. So we're doing a lot of work around testing. We've been partnered with City of Boston to do testing. If for those that are kind of familiar, in addition to the different access points for testing, East Boston and City of Boston have been doing what we call pop-up testing in different areas. But we've done some enhanced testing in East Boston specifically, so that we could both test folks, but also to avail information and resources to folks as they came through our testing sites. So that's kind of what we did, to answer your question, Ted. But in terms of like what the concern it raised, obviously it sends off a number of alarms for us, because we also recruit from the area. So not only was it a concern for how our patients were presenting, it's also a concern as an employer, because our staff are also subject to becoming infected and being out of work and not available to serve patients. So a lot of work has gone into infection control and managing our facilities as well, which we didn't talk a lot about, just the investment it takes to make a safe environment for patients to be able to come and see you, to the extent that telehealth is not an option.
Dr. Wright?
Yes, Mr. Wilmot, you hit on so many areas that is the same over here at Whittier Street Health Center. Human behavior is a funny thing. It's a strange thing. Certainly when the COVID-19 really hit here in February and March, of course, like everyone else, we were all afraid. Each day it seemed plans seemed to change. How we managed things seemed to change. You may remember at one point early on, face masks were not really reinforced. I mean, there was a time where we didn't want to wear face masks. We didn't want to scare off our patients and cause any any panic. Well, hindsight is 20/20, and face masks will likely save us from this. But certainly at the beginning, we were all in panic mode. The public, they understood at first that they really needed to stay home. They needed to stay in, needed to stay away. And as providers, we knew that we needed to distance ourselves from the patients so that we didn't infect the patients. It was really a safety concern. And as time went by, we got a little better handle on what our protocols should be. And I say we, the editorial we, the medical community. We did find that, yes, masks were, in fact, what we needed to wear, social distancing, all of these things started coming into play. The numbers were extraordinarily high at first, but then they started to level off and even decrease a bit. And human behavior, the point that I'm making there is, as things got a little bit better, people relaxed a bit. Our patients relaxed just a little bit more. They started socializing when they shouldn't have socialized. And we remember we're in phase 1 and phase 2 and all of that. Things seem to be getting better. We still didn't have a cure, and we still don't have a cure for this COVID-19. So in that regard, things haven't changed, but how we're handling it seems to be a little bit better. But by then, the horse had left the barn. People a little more relaxed, they're getting out, they're socializing, they're actually going to the graduations and the parties that they've been missing, and hence, this is where we are now. Things are actually getting worse, okay, because we are relaxing a bit. We still don't have a cure, we still don't have a vaccine. Throughout this whole thing, as Mr. Wilmot had said, the PPE issue, we didn't have enough gloves, we didn't have enough masks, we didn't have enough hand sanitizer, we didn't have enough of anything at first because that initial surge really just about obliterated any of the supplies that we had. And we're still playing catch up from that. So here we are. Things were horrible, they got a little bit better, and things are on the rise again. And that may be, in fact, some more of this behavior, human behavior. Kids are going back to school. Some schools are all remote teaching. Other schools are hybrid. Others are in-class teaching. So there's more exposure to this virus that we still can't quite control at this point. And we're now the 4% testing and all of that, and so things are increasing again. So that's basically where we are at this point. Throughout this, we have patients that have diabetes and hypertension and cancer, all of these chronic illnesses that have gone basically untouched. Telemedicine has certainly helped, but there has been a reluctance by a lot of our patients to partake in the telemedicine. They want to be seen, they want to be touched, and we get that, we understand that. But telemedicine has actually saved a lot of our patients because at least we're able to be in touch with them. We can find out if they need a prescription. We can find out if they have an issue, a medical condition that really needs to go to the emergency room as opposed to just stay at home and wait it out. So this is still unfolding. There's a lot of good from the telemedicine, but we have to see where it's going to go, and I'm sure we'll open that up and talk more about that.
So I want to remind folks that we welcome your questions. Please type them into the Q&A box. We really value and we'll get to as many of the questions as we can this evening. But it's very simple. Type a question in and we will raise those questions. Before we get to those, I'll turn to Tim. Tim, given that you have two health center folks here, what are the kinds of questions that you would want to raise?
Well, this issue of how places like health centers are going to continue to innovate to provide care in an environment where, let's be quite honest, there may not be additional resources. There may not be, the financial support that's needed, right? So Greg made a great, and Stephen, I mean, the costs alone of a medical office to have to keep their offices safe to allow for in-person care, the costs in doing that, I've read different estimates are just potentially bankrupting to certainly private offices, right? But they're gonna hit hard, publicly funded places like health centers as well, and so this is what we would call a cost of doing business that largely didn't exist pre-pandemic, and now it's a huge part of the balance sheet, right? And so that's one thing I'd certainly be interested in hearing more about in terms of, if we're looking at another 1 to 2 years of this, hopefully not, but how can those costs be accounted for and absorbed, particularly when on the revenue side of the equation for community health centers, you may be facing flat revenue growth or negative revenue growth. So that would be certainly a question I'd love to hear more about. Just how do you two see the issue of balancing the books moving forward, and where do you think innovation can help do things more efficiently, so that you can absorb those financial cuts or losses if they continue in any form?
Dr. Wright, would you like to go first?
Sure, absolutely. Well, that's the big $64 billion question, I think, the cost of doing this business, and that's what we're all scrambling about. I mentioned that the telemedicine has been very beneficial for us to continue to keep contact with our patients. And quite honestly, it's one of the main drivers at this point to help defray the financial burden that has been on the medical community, where at one point we were hardly seeing any patients in clinic. Telemedicine was the only thing that was generating any kind of revenue, any kind of sizable revenue. And I foresee that as continuing into the future in some form. So hopefully when we can get back to days like the good old days, where we could actually see a patient in our clinic without having to worry about this devastating virus. When we can get back to a bit more normalcy, I still see a place where telemedicine is going to have a place in healthcare. It will likely be in a hybrid form. So we'll see a patient in clinic, and perhaps for the follow-up visit to review the labs or to check to see how a medication is doing, that may be able to be performed via telemedicine, a virtual Zoom visit or the call. And the key is to be able to make that a billable visit, as it is right now. So I foresee that still happening. We are still using virtual group meetings. We will see a group of patients in a virtual format. Staff meetings are held virtually as well. So telemedicine, thank goodness, is here to stay, I hope. We just need to ensure that that is still a billable visit. More innovation, the more things stay the same, the more things change, or however that goes. When I was young, my pediatrician used to come and visit me at my house. I don't know, some of you may not remember that, but I certainly do. And for a long time, my pediatrician came, and then when I was about 12 or 13 years old, healthcare system changed, no more house calls. I think that is going to be a way to reignite the finances for the medical business, to go out to the communities. And we're doing it. Mr. Wilmot, you mentioned also that you're going out and doing pop-up testing. We've been doing the same as well. But we can also think about doing some treatment as well, not only giving advice to our patients when we go into their communities, when we go to see them, but we may be able to do some treatment, whether giving immunizations, doing certain screenings, in fact, put a provider in our van. We've got 2 vans that we send out, put a provider in there and actually see some of the high-risk patients who are very vulnerable. It would be too severe for them to come out into the clinic, but we can go to them. I think those are some of the innovations that we can look toward. We used to do it 50, 60 years ago. So we're just thinking of an old thing in a new way. I guess that's what it is. And that is a definition for innovation, if we can look at it in that light. So I see that as a part of what's going to help save the medical community. So pop-up testing, sending vans out, we are in fact bringing our mobile van to some of the polling areas, some of the pop-up testing. It's all about our relationship with our patients. Our patients in the community trust us because they've been coming here for years and years and years. So if they can't get to us very well, we will try to go to them, try to keep that relationship going and trying to keep them safe at the same time.
Greg?
Yeah, so Dr. Wright hits on a number of points. I'll try to touch on some other items. I think on the question around, how do we continue to keep our doors open, given the impacts COVID has on our business, on our financials. One thing I'll mention is, community health centers in general, historically, aren't necessarily always well funded, right? So, I think it's not foreign to us of having to think about how do we innovate and how do we get creative in order to make sure we're able to serve our patients, and doing so in a way that, we're being fiscally conscious. So that's not new. I think what was interesting here was just how quickly and how drastically that impact came, like many businesses, quite frankly. And so what was helpful here in Massachusetts is that this state is, when it comes to healthcare and human services, I would say Massachusetts is best in class, in the world and in the country. And our healthcare system, with all its warts, is one of the best healthcare systems in the country. And so I do think when you think of how quickly our local government responded, payers like MassHealth is one of our biggest payers within the community health center space. They responded pretty quickly to say, we're going to reimburse telehealth visits at the same rates that we reimburse in-person visits, right? Just to remove some of those barriers. They quickly kind of organized some additional funding, supplementary funding, to offset some of the losses so that we could preserve these critical access points to healthcare in these communities. And the federal government as well responded with some additional, whether it's grant opportunities or other opportunities to augment some of those losses. So those were things that I think were able to help us out, and of course, collaborating with them all along the way to say, here's where the gaps are, here's where our challenges are. Of course, there were some things that we couldn't get past, PPE and other things that just were, funding couldn't solve. But I will say, being able to maintain our workforce, keep people on payroll, invest in the necessary protocols to keep our organizations safe for the public. Those were things that it was vital. In addition to telemedicine, and I would say, without rehashing some of the great points Dr. Wright made around telehealth, one thing I would highlight around telemedicine that we have seen more visits in telemedicine on is behavioral health care services. Within the Black and Brown community, it's behavioral health in terms of folks utilizing behavioral health care services, it still remains underutilized. I won't get into kind of all the nuance as to why that is, but it's certainly underutilized. In the advent of telehealth being utilized as the primary vehicle to deliver behavioral health care services, we've seen drastic increased engagement from patients in those services. And that's something that I don't think we would ever look to go backwards on, right? So, silver lining with COVID, the very few that there are, that was one of the great kind of innovations that leapfrogged us forward around behavioral health care in our community, that I think will pay dividends down the road. So we're very excited about what happened in that space. Some other things that we have done around innovation, we did do, we've trialed it at our health center, mobile vaccination vans for pediatric vaccinations. One of the things that we worry about, and we haven't necessarily talked a lot about it today. I think any of these topics could be a long discussion, but there were health disparities in our communities, well documented and researched before. And what COVID does is it exacerbates in many ways those disparities. Tim, you went through a number of disparities just around how folks have access, care amidst COVID. Those gaps existed pre-COVID as well, and COVID just kind of almost sets us back a little bit in those different areas. So we were very concerned about losing ground where we've had great success, in recent years, and pediatric vaccinations were one of those areas. So we did pilot a mobile van to go around and do vaccinations for kids. That was very successful in that we were able to treat kids outside of our facilities, where we were still kind of getting those safety protocols in place, where the community was still not, confident that they could, go out and go out into the community safely. So we were doing things of that nature. But the innovation continues. Use the term, Tim, reimagine. We're looking at, like many industries, reimagining a whole host of things. Certainly the way we deliver care, but even the way we think about our administrative offices. Working through Zoom. I've been on Zoom meetings all day, today, and a year ago, that wasn't the case. I'm scrambling between meetings, getting in person. Sometimes you're conferencing in on a phone, and it's hard to hear, and all these things. So there, certain things have gotten a lot better, and I think virtualization of large forums like this, where you can have more people participating in a forum because you're no longer kind of limited by physical space. Those are all things that we're looking at now to not only transform how we think about our real estate in an efficient way, but also how we improve the employee experience, so that we can have more folks working remotely and able to avoid the commute into the city, and not deal with parking and all those kinds of issues. So I think, as we innovate, the rest of the, other industries innovate, I'm really excited about where we're headed with this. I think we learned a lot around disaster preparedness. But I do think there were a lot of great lessons learned over the last several months, more lessons to continue to learn. But health centers certainly will continue to innovate to make sure that we can respond to the needs of, to our patients and to the needs of our community. So I'll stop there so that we can get some more questions in. But
yeah, you've both talked about the desirability of having collaborators with whom you've worked. One of the questions that's come in is around whether there's been any collaboration with people at the census in terms of the way they are out in communities, trying to assess who's there, with consequences clearly that relate to your work. That is to say, if there's a significant undercount, then federal funds that might flow into your centers could be reduced. To what extent have you been able to work with folks at the census to follow up with the patients that you have and to help identify some of the key issues that they're also trying to identify?
Yeah, it's a great question. I'll answer very specifically on the census point. We haven't necessarily collaborated with the census, and there are probably a few reasons why they may not be the best group necessarily for this purpose to collaborate with. As you think about our population, there's a large immigrant community, and in some cases, especially recently, again, some of it perceived. This is not necessarily a comment on the census itself, but some perceptions just around how safe it is for immigrants or folks that may not have legal status to engage in some of those processes and be counted. That sometimes it makes it harder sometimes to engage with our patients if they're concerned about being documented in some way that could affect their families in adverse ways. So I think what we have done instead is we've certainly have partnered with a lot of local organizations to use data and to use opportunity where we are engaging with residents in our communities, to use those opportunities to provide additional information, to provide access to resources and make sure that people understand how to access care, how to access testing. So we have done that, just haven't specifically worked with the census to do that. I'm Dr. Wright, I'm sorry.
Yes, and I agree with you, Mr. Wilmot. I am not aware of our work with the census either. It was never brought to my attention, and I'm not aware of that. It's all about relationships and the relations that we have with our patients. And as you mentioned, Mr. Wilmot, a great proportion of our patients are immigrants. And there's always this issue of trust. And as you said, the perception can be one of mistrust for a variety of reasons. But we have not aligned with the Census Bureau to get information or to work in collaboration with them. Our patients rely on us to be private with their information, not to share the information that would certainly put them in harm's way. And we pride ourselves, as I'm sure you do, Mr. Wilmot, and East Boston Health Center, at protecting our patients and our patients' best interests. So I do agree exactly with what you're saying, sir.
One of the questions that came in does relate to how you use your real estate, and whether there's anything to be learned from the current situation that would enable you to use that real estate more efficiently. And in partial response to that question, I'm reminded of my own mother, who was a public health nurse in New York, who worked in a public school during the school year and provided all kinds of basic care to the children in that school. And then when school was out during the summer, she picked up all of her files and took them to a neighborhood health center that was located in a public park, and continued to serve exactly the same kids in the neighborhood in that public park. Now of course, it would be a transfer via computer, but what is it that you're learning about the use of your current facilities that may be useful as you move forward, particularly given that you're both working in neighborhoods where the populations are increasing and becoming more diverse, and may look to a physical place as much as a home visit for their services?
Great question.
Well, I'll start with some of the services that we have here, utilizing our real estate. We have been able to provide emergency daycare during the shutdown early on for the support staff and essential workers. We've been able to provide information for housing. We partner with several housing agencies, and we advocate for housing and to reduce housing evictions. Our food pantry has remained open throughout the pandemic to help our patients with food insecurity as well. And we take that even a step further. We have our own garden here that we invite our patients to participate in right here on our premises. We have a fitness center that is open to the community to become members, and so we're using our physical building and our property to help the community out, to bring them in, and to do and to help them in ways that may not be obvious to some. Certainly, near the beginning of the pandemic, when our hospitals in the area were inundated, the intensive care units were packed, the general hospital rooms were being turned into ICUs. There was a discussion to actually have our center serve as an inpatient facility. There was some discussion about that, and so we were considering that, and then other centers were able to open up, the World Trade and Convention Center, and that allowed patients to be taken care of there. So we didn't enter into that, but we're open to helping the community in any way that we can, and even insofar as turning our facility, maximizing it, optimizing it for whatever is needed, whatever that makes sense. So those are some of the few things that we've done with our real estate here.
Yeah. And I guess I would add, I think with the question, with additional kind of just percent of activity being done virtually, should some of the facility costs of providers come down, and therefore, should some of those savings either be passed on to consumers, or how might those savings be accounted for? I think broadly, I would hope that that's how that would work. That ultimately, if healthcare is being provisioned more affordably, at lower costs, or more efficiently rather, that those savings would be passed on to consumers. So I definitely, just as a healthcare professional, that would be my hope, is that is how it comes together. Specific to East Boston Neighborhood Health Center, I think for us, Ted, you mentioned we're growing. So if anything, I think we'll continue to think about how do we, as we are able to decant our campus and decompress our campus, how can we use that kind of newfound space for other services, right? Because I think the reality is, you know, we have a lot of folks that we want to provide care to. You know, we you know, in many ways, our physical space is more of a constraint, and the more that we can decompress or free up space to see more people, that's probably more how this will help us. I do think administratively, you know, we're a growing organization as an employer as well. So I do think it's going to help us kind of as we do our future real estate planning, that we don't need potentially as much of a real estate footprint going forward. But I think we're still learning kind of what is the real opportunity, what is being asked of us from the community, and being prepared to respond to that. But I would hope that if we see efficiencies as a health system, that ultimately consumers would reap the benefits of that.
We have questions from a couple of folks that are overlapping in some respects. That is, in the midst of COVID, you're also dealing with some other longer term questions within the community, including opioid addiction, including domestic violence, including suicide rates, not all of which are visible to everyone. How has the pandemic affected the work that you're doing in those areas?
Yeah. So I'll just very quickly, I would say, you know, I think the data is showing that the rates of those issues to be increasing amidst the pandemic for a myriad of reasons. I won't get into that, but the data seems to suggest that, yeah, we're seeing more increased substance use disorders and suicide, you mentioned, Ted, and other kinds of domestic challenges. So I think I think the nature of COVID, and particularly in Black and Brown communities where a lot of these disparities existed before, simply exacerbates those things. And I think the hope is that as we pivot out of kind of crisis mode, and I think we're you know, kind of making the, you know, turning the bend there, right? Because we've been able to kind of think creatively around how to respond to needs. We're starting to see the data and be able to plan with that data in hand, in targeted and in intentional ways. I think we'll continue to develop those plans, but those are issues. And as the health system emerges out of kind of reacting to COVID in terms of treatment, in terms of testing, and dealing with like kind of some of the immediate kind of post-acute complications of COVID, these more longer term issues, you know, whether it's you know, opioid or substance use disorders, whether it's, you know, other issues as folks are, you know, forced out of the workplace, or there's any number of things that affect Black and Brown communities in disproportionate ways. I think we're going to need a real intentional response as a healthcare system to ensure that the gains we've made around closing some of the, you know, the disparities in healthcare, that we don't lose too much ground. I can only presume we'll lose some, but hopefully we can start to be very proactive and anticipatory of those issues, and come up with a really thoughtful, strategic response.
Yeah,
Tim, were you going to?
Yeah, I was gonna. I kind of wanted to just pop back to the prior question and talk a little bit more about the payer side, because I think that's sort of a perspective we haven't discussed as much yet. And I think, you know, when we talk about innovation, you know, the reality is, the prior question from one of the attendees was around, telehealth. And if you can increase the number of counters using telehealth with less physical space, does that enhance the bottom line of the facility? I want to point out, I mean, the shift to telemedicine is not something that most payers look upon with glee right now. There's a reason they haven't wanted to provide pay parity for telemedicine for all these years. And though many are begrudgingly doing it now, they're doing it in part because overall utilization is still lower than where it was at before the pandemic. So they're not losing money per se. And this includes even funders like Medicare, Medicaid, the government as well, right? How long that willingness to provide equal compensation for telemedicine visits in line with in-person visits, I don't see that lasting forever. And in fact, I think there'll be private insurers that by the end of the year will, across the country, will start to dial that back. And so that's going to put a real strain and a real pressure. The cost for care will be shifted more to the provider side if providers can't find a way to get patients either through telehealth very quickly, so their number of visits and their volume increases, or they can't get people back in person. So I think that's really an important issue to point out, which is insurers are, also very interested in making sure that the shift to telemedicine, for example, doesn't negatively impact them. I mean, we're seeing private insurers saying that they're going to have to raise rates 30 to 40% on people next year, right, on subscribers. If that happens, you will also get, and this definitely impacts, places like federally qualified health centers, it will impact the uninsurance rate. I anticipate you're going to have many more people falling into the uninsured, not able to qualify for Medicaid, but no longer able to afford health insurance, private health insurance. And those people in certain areas of the country, certainly urban areas, rural areas, they're going to be a larger group of patients now that also needs to be seen. So that's one part of it. And then the positive, though, part of the payer issue, I think if anything, this pandemic spells the end of fee-for-service medicine or close to it. I think what you're going to see increasingly are providers that are going to much more quickly embrace models of payment that they have been resistant, some of them, to embrace previously, like global capitation and global payment systems that will pay them, big pots of money in return for caring for big populations of patients, and that's where the mix of telehealth and in-person care actually could benefit providers in that kind of payment model. But, I talked to a primary care practice, that was one of the few I talked to that said, we didn't take much of a financial hit during the shutdown because most of our primary care contracts with our insurance companies are globally capitated. So we get the same money whether we see people or not. And that allowed them to actually manage the shutdown very well. And so I think that's a positive. I think if this pandemic speeds us towards payment models that allow, and again, providers are going to have to, be very innovative in how they provide care within those payment models and not lose money. But I think if they can figure that out, I think that, that can be a real positive, not only for the providers, but for patients. But there's no doubt that, the payer side of this is, the payers have not been heard from yet. And they will, because they're not, and this includes public insurers. I mean, as utilization rates go up with telemedicine, there will be a lot of pressure to dial back the reimbursement for those services.
We have a couple of questions that I think relate directly to that. One is around whether, if physical facilities don't need to be utilized as much, there's an opportunity for providers to actually generate greater profits, to the extent there are profits in this business, because they don't have to use the facilities as much. And then a related question came in from a different person who used telehealth for an initial appointment, which was then paid for, only to be told that they would need to come in to the center for follow-up work, which also had to be paid for. And of course, there was additional time that went into it. And that particular individual felt as though they might have been billed twice for essentially what proved to be the same service. So how is it that the providers help to manage the flow of service in a way that is fair to the patients, whether they're using telehealth or not, and also doesn't necessarily lead to deficits for the health centers themselves?
Yeah, I'll start with a couple comments. Thank you so much, Dr. Landsmark. Those are great questions. We're trying to do everything, with my provider hat on, we're trying to do everything with safety in mind. We want to protect our patients. We want to protect our staff as well. The person who sent the question about his initial visit was telehealth, and his follow-up visit, he was asked to come in. I can understand where the provider was coming from with that decision. And yes, at this point, providers are pretty much controlling if the patient is coming in or if they're going to do a telemedicine visit. I think the provider who made this choice was initially trying to speak with the patient to determine if the patient may in fact need COVID testing before they even come into the clinic. On an initial visit by phone or virtually, you can get the history, you can get the story of what's going on with the patient, what his or her medical history is, the surgical history. If they've done any of, we know all those COVID questions. Are you having any cough? Are you having any fever? Have you traveled here or there? Have you been exposed to someone? That would allow the patient, the provider, to direct that patient to testing first before he or she comes in to the clinic. So in that regard, for this particular scenario, I can understand that. And having the patient come in for a follow-up visit in the clinic would allow the provider to do the physical exam, get the blood tests, do those types of activities that need to be done in person. So it's not, at least during this period, during the COVID period, it's not unusual to have that initial visit done by phone. And it's really a safety concern for everyone at that point.
And what if it's not a COVID-related medical concern? What if the person has some sense that there's something else going on, it's not related to COVID, and they express that? Would they still, in effect, end up being billed twice for, once for the telemedicine and then again for the site visit? Tim is shaking his head saying yes.
Well,
go ahead. Yeah.
Well, no, I'll talk just in generality. I mean, from all the primary care offices I've been talking to and, all the sort of research I've been reading, the reality is nothing gets done without being billed for. So whether it's a telemedicine visit or it's an in-person visit, most offices are going to end up billing for it. And this goes back to my earlier point about this is exactly what payers and insurance companies are afraid of, that there'll be a double dipping or a triple dipping going on, that normally a patient would go in, get triaged and treated in that same visit, which is only billed once. But now that turns into, a phone consultation that gets billed, followed by an in-person visit that gets billed. And it's essentially the same diagnostic reason, but now it's two visits that have to be paid for. And not only does the insurer have to pay for that, but potentially the patient has to pay for that if they have like a high deductible health plan, for example. So this is where I think to Dr. Wright's point, providers have to be I think they're not there yet in terms of fully thinking through how this model is supposed to work. Certainly with COVID potential patients, what everything Dr. Wright says is absolutely true. And you're doing those things for safety, but for patients that may be presenting with something different, I think right now the approach of a lot of primary care providers is, hey, there's a visit, I'll bill for it. Let me talk to the patient by phone, I'll bill for it. Let me bring them in, I'll bill for it. And I think that won't be sustainable. That also puts more burden on the patient and more out-of-pocket costs. So, I'll turn it back over to
if I could just, I would just comment to say one of the things, for us, certainly, telehealth, can address some things, but you can't necessarily diagnose all things or treat folks exclusively through telehealth. And I will say for us, that scenario of a telehealth visit took place, but required upon evaluation required in-person care happens. But if you were to look at it out of 10 times, it happens 1 out of 10 times. So it's not a common occurrence. I would say it helps very much to keep many other folks from having to come in person. So I'm guessing when most folks are coming in to the practices, they're not filled with people, right? So I think we know that people aren't necessarily kind of double dipping per se, but some folks do require that additional consultation just by virtue of what they may be presenting with medically. So I think that happens, and then there's other scenarios that happen. But I will say within the community health center, kind of going back to Dr. Wright's point, it's been really important for us to kind of treat people in the lowest risk setting where possible, both for staff and for patients. And so where telehealth is a viable option, I think that's what we're defaulting to, just so that we're not bringing folks out into the community and necessarily kind of bringing folks into our facility that do not need to be there. And that's something we've done with both patients and with staff. We're trying to keep staff out of facilities and where their job doesn't require that they be there. And if they can do their work virtually, we're looking to do that. So I think we're learning a lot. I think we're learning a lot around the standard of care. The data will be really interesting when this is all said and done of, were outcomes any different for folks that were treated via telehealth versus, historically through in-person care? Are there any differences in outcomes? And I think that's going to make a big difference ultimately in what payers are able to do or not do when it comes to reimbursement. Is the outcome any different based on how folks are being treated? And I'll just make one point that I wanted to just make mention of is, and this isn't always true, because I will say payers, I've seen payers on the forefront of innovation as it relates to shaping healthcare. But in most cases, payers lag providers in that some of the innovation is happening at the practice level. Sometimes consumer expectations and how consumers want to receive their care is ahead of where the payers are, and sometimes the payers are catching up to the industry as they learn more and have more data from from the industry. So I'm expecting a lot of learning to happen kind of post-COVID around what is the right reimbursement amount. That was always an elusive thing that around telemedicine, because there weren't necessarily enough people participating in it. I think this season will provide ample data for us to really look at and understand what is the true cost of a telemedicine visit. How do you set the right payment levels to that? And ideally, the system would recalibrate. It's going to take years because we've invested a lot in the infrastructure we have to for the system to function the way it does. which is why we haven't made, to your point, Tim, made that full pivot to value-based care. We're still kind of tethered to this fee-for-service system. There's a lot of investment in that fee-for-service system, but I do hope that in time, with innovation happening as rapidly as it's happening, with a lot of the data that we have, that recalibration ultimately can happen, and that it ultimately is to the benefit of consumers, whether it's in the way they get care or in the cost that the cost of care for them.
Well, and just to tack on 2 points to what Greg's saying, the 2 areas we really need to work harder in right now to catch up is, one, patient education, because frankly, patients are being thrust into this new model of care, really not having much input up to this point in whether they like it. If you look at surveys right now, the jury's out on everything from whether they're willing to pay as much for televisits as to whether they feel it is as good an experience. So we need to involve the patient more. I had to call, for example, I had to call my insurer to even find out if my telehealth visit would be covered. I had no idea. And, I'm a very well-educated person, right? So imagine people who just don't have any understanding, even maybe how to contact their insurance company to ask the question. And then the other issue, which Greg touched upon, which is really important, is the research on telemedicine and quality of care is very fledgling. And we're going to need to catch up with that research, because we're going to have to understand if the quality of care we provide through telemedicine is really as good in a lot of different areas as it is for in-person care. And we can't assume, that it is, and we can't assume that it necessarily isn't. But until that research catches up, we do need to judge these innovations, pretty critically in terms of whether they're big substitutes for the way care has always been provided.
So 2 last questions, one of which relates directly to telehealth. Both of you as neighborhood health center professionals are dealing in very diverse communities. And in talking about telehealth, we're essentially talking about using a computerized, digitized platform that doesn't always recognize cultural differences and may, in and of themselves, represent barriers to people accessing the kind of care that you've been providing. So what do you see as a way of addressing that issue of cultural diversity? How does that impact on the kind of disparities that we may be seeing? And then my very last question is, what are the takeaways that you see, apart from some of the issues around telehealth, that are learnings from COVID that are going to impact on us moving into the future?
Yeah, I'll kick this off if you don't mind. Regarding the telehealth and computers and the barriers, it is an issue, a major issue. So for several reasons, we have patients who may not be able to afford the hardware, just simply getting the laptop or the smartphone. And then there's the subscription service, the internet, whatever. That's another financial barrier. And even under the best situations, when finances are available and their infrastructure and their building will allow for the internet, then people just may not be able to understand how it works. At the beginning of our webinar this evening, I was running around trying to get things straight myself, and I consider myself fairly educated. So there's also a barrier there. It is difficult. We have been discussing being able to furnish some of our high-risk patients with the hardware and with the education to actually be able to communicate easier with us. So that's one of the thoughts. In situations like this, any communication is better than no communication. And I think that's why there's the support for the telehealth. But without a doubt, there are serious barriers to the computerized age in terms of this type of communication. And lastly, I'll touch on the takeaways from this COVID experience. From a purely scientific standpoint, a medical standpoint, we have seen this virus that has seemingly come out of nowhere, and for what reason, we don't know. But scientifically and medically speaking, a virus is a virus is a virus. It will behave a certain way, which is it's just trying to survive. It will try to find an opportunistic host, in this case, the humans, and it will utilize whatever we have in our bodies so that it can replicate. That's what viruses do. Certainly when we learned early on that there was this new virus, we have the greatest minds in the world working on this, but we just lost sight of the fact that this is a virus and it will do what it's going to do. It will spread. It will go from person to person if it has a chance. It'll go from state to state, country to country. And moving forward, we just need to remember we need to do those common sense things to control the virus. Because at the end of the day, the virus will do what it has to do to replicate, and we have to respond in kind and try to mitigate it at every point we can. And that is using masks, social distancing, washing your hands, not getting in gatherings very close. Those are just simple, basic things that should anything like this happen again, we really have to take care of business, so to speak, early on. So that's the biggest takeaway that I have at this point.
Greg?
So I know we're close on time, so just a couple things that I would highlight around Dr. Wright's comments. I do think, on a maybe on a positive note, the challenges of access are always there, right? So access to technology, access to the equipment necessary to engage in healthcare in this way, that certainly is an issue, right? I will say, things, very practical things that we should be looking at. I think video-enabled telehealth has been the primary vehicle by which you can be reimbursed for a telehealth visit. I do think looking at telephonic visits as an alternative to video visits is a reasonable compromise to make sure that we can preserve access to medical care for folks that do not have a smartphone or some of the other technologies, a laptop necessary to do a video visit. So I think that's something that should be further explored. I know it maybe is a step down to the standard of care because the provider can't lay eyes on the patient, but I do think a lot can happen in a conversation, depending on the nature of the visit. So I think that's a very practical thing that we should be advocating for, is parity around telephonic visits alongside video visits. In terms of some kind of on a positive front, because COVID so drastically changed the way that all of us interact with everything, right? I'm spending so much time on Amazon and whatever else. I can't imagine a world where I'm going back to the mall in the same ways. And it's fundamentally changed our behavior in how we utilize technology and how we virtualize, our lives in ways that I think will complement healthcare as well. So it won't feel as foreign because we're not in it by ourselves. So folks aren't just using telehealth for healthcare, or using their smartphone for healthcare. They're using it for many other things, for how they socialize and how they do other things. So I think the learning curve will be, smaller because I think we're primed for using technology in different ways than perhaps we had been historically. When it comes to learnings, what I'll touch on is, what was interesting with COVID, and in part, to go backwards to go forward, but what was interesting about COVID is early on we saw the data. The data was presented to us as large numbers without a lot of demographic detail underneath it. And we were all very scared, and many of us continue to be very scared, rightfully so. What was interesting is as the months played out, we started to see more detail on, the demographics, the age groups that were at higher risk. Ultimately, the racial and ethnic kind of details behind who was more likely to be hospitalized, who was more likely to die from this disease. And if you were to ask many of us at the start of that, we probably would have guessed it. But of course, there were disparities in that. There was, disproportionately, Black and brown communities were more likely to be hospitalized and more likely to die from COVID-19, right? And what is, that learning was there. I think we probably could have guessed it because disparities on any illness or chronic illness, that they kind of, break along racial lines. I think the go forward, though, the learning, how we use that learning is to recognize and anticipate the fact that when the vaccination, should that come available soon, I think we're all praying it does, that we're going to need to really focus on equity in a different way to make sure that that gap is closed, right? And so that's one thing on the vaccination. I think even beyond that, we're starting to learn as a medical community that COVID is not a 2-week thing. I know some folks can recover from it within a couple of days, perhaps because they have access to superior treatment and can really get back to their normal life really quickly. That's not the case for a lot of people. And a lot of folks are seeing some post-acute complications from COVID that are creating new chronic illnesses, myocarditis, by example, heart conditions and different things that will plague our communities. And again, because of the disproportionate impact of COVID on Black and brown communities, we will likely see disproportionate impacts of post-acute complications from COVID on Black and brown communities. And so I think as we think about the research and how the healthcare community can start really anticipating what is likely to happen based on all the history we have on other illnesses, if we can get ahead of that sooner with a focus on equity and closing those gaps as early as possible, I think that would be to our benefit for sure as we try to really address some of these issues. So I'll stop there and just again, thank you guys for the opportunity to respond to some of these questions and share insights on what we're learning.
Tim?
Well, I've learned a lot tonight, so that's always a good thing. So I appreciate Stephen and Greg. I always love to hear about, what goes on inside places like federally qualified health centers, because they do such important work. I would just say anyone who knows how this is going to ultimately turn out, well, I could use your advice on other things too. I think we're in, I think there's going to be, I'll say this, I'll make 2 final points. There is going to be a tendency, a reflexive tendency for providers in the health system to want to go back to the old ways of doing things as soon as they think things are returning to normal. In fact, I'm doing a study right now, primary care offices. As soon as many of them could get patients in the door, the telemedicine use went right down because they can still get more money and generate more revenue from in-person visits. And they feel safer doing that because they're worried the telemedicine reimbursement is going to go away. So I think the biggest thing to convince the health system of is that there won't be any going back to the way things were. This is and the ones who innovate, the ones who get ahead of the curve, are going to be the ones that will be most successful. You know, I was reading today about the Mayo Clinic, and you know, it's the Mayo Clinic, right? So they're well-resourced, famous brand, but they're using this, you know, they're using this time period to basically transition to a very fully digital platform of care moving forward. And so places like, you know, them, Geisinger, Kaiser, these big systems, they're using the pandemic as an opportunity to move full force into new payment models, new ways of providing care that use digital platforms. And so everyone who provides care, federally qualified health centers, rural health clinics, they're going to have to find ways to also get on that train, right? And it may be more challenging for some of these other places that aren't as well funded. So that's one point. And the final point that goes with that, though, is some of the ability of providers to innovate moving forward in new ways is probably going to have to, you know, bring, you know, technology corporations and other players who have deep pockets into the conversation, because to think that federal and state governments are going to be able to fund this kind of innovation they're just not going to happen. And so, you know, when I think of the National Health Service in the UK, you know, making a deal with Amazon to put Alexas in people's homes, you know, so that they can get care to people, you know, those are the kinds of partnerships that this pandemic will probably accelerate, because that's, you know, as the old saying goes, you know, that's where the money is. And it may not necessarily be a bad thing, although there's a lot of issues that raises. So, but again, thank you. This has been a great discussion. You know, I have many pandemic discussions these days as an academic, and you get kind of fatigued by them, but this was a good one.
Well, thank you all very much. This is a very rich and informative conversation. And I think we touched upon a number of things that we are not seeing discussed in the general media. And, you know, the next few weeks will give us a better sense of where we're all going in terms of the pandemic, and what national policies may be shaped, both in Washington and in those centers where the payers are going to begin to weigh in. I remind those of us who've participated that next week we will be talking about environmental justice and community engagement with issues of resilience and environmental justice. The week after, we will be hearing from two law professors who will be talking about the status of the law and what's going on in the Supreme Court. And the week after that will be our Wednesday after the national election. And you know what we'll be talking about in that session. So thank you all for participating and being a part of tonight's discussion. And I look forward to seeing you in the weeks to come. Good night.
Thank you.